There's a number of questions here, some of which I'll have to shelve till the afternoon session where it will be more appropriate, because some of it will be answered by our speakers in the afternoon. So I'll start with the first one, and I'll answer this one. It is, what is the therapy of choice for a patient who had a 1.3 centimeter carcinoid removed during an acute appendectomy? The margins were clear, but the tumor invaded the mesoappendix. It was well differentiated, and all biomarkers have been negative for 1 year following the surgery. So, my answer to this is pretty clear from my point of view, and the therapy of choice is no therapy. Okay, this patient has been treated. Tumor has been removed, and the margins were clear, and the patient's been stable for a year after surgery. The patient should still be followed, of course, by hopefully a medical oncologist with expertise in the field. So the patient will still be monitored for any recurrence, but an appendiceal carcinoid discovered incidentally on surgery is usually, once it's resected in toto, is usually curative. Any comments on that?
Sure. You know, when I was one of the slides, I think there's medication for that. As I mentioned in one of my slides, that you have to consider the biology of disease, right? And so if you have a small, well-differentiated tumor, one would consider that a local disease, and therefore a local therapy would be appropriate. So if this was a small, incidentally found, well-differentiated lesion in the tip of an appendix with no other extent of disease or microvascular invasion or lymphovascular invasion, then an appendectomy could be deemed appropriate. I would slightly argue a little bit that if this person had mesenteric extension of their disease, that the standard for other tumors like appendiceal adenocarcinoma would be doing a right colectomy with a wide mesenteric resection. So I think that you have to weigh a couple of factors in terms of the risks and benefits. I think the yield on doing a right colectomy would probably be low. However, so if this is somebody who's 70, 80 years old and multiple comorbidities, sure, following would be appropriate. If it's a 30-year-old person, I would probably lean more towards having a right
At the time of the original diagnosis, yes.
No, I mean, I've gone back and have, when scans are negative, and again, this is anecdotal, so again, I'm going to acknowledge the fact that the yield is going to be low, but have I certainly gone back and done a delayed right colectomy, and then boom, there's a node sitting in the base of the mesentery that wasn't picked up on imaging? Absolutely. So, you know, it's a risk-benefit situation. The yield is going to be low in a young, healthy person with mesenteric extension, as you mentioned. I don't think that a right colectomy is out of the question.
And just to follow up, I totally concur with Dr. Hein and Dr. Antini, pardon me. But in size, this is one part of the bowel that size does matter. You move into the small bowel, the ileojejunal carcinoids, and the size of it is absolutely unimportant because small tumors get met. But in the appendix, that 2 centimeter cutoff has been predictive. And I think the judgment of the colectomy part of it, hemicolectomy, is very, very keen.
Okay, so we have some differences of opinion on that. Next question: how big does a tumor need to be in size to locate it? And there's going to be 2 answers to that. We're going to address, I think, the first one. Dr. Metz can answer us on that from his point of view, from the GI point of view, and I think this afternoon we'll have Dr. Mortsikis answer that from a scanning point of view.
Sorry, I'm late to the party. Hope that the first questions weren't all the way exciting. How many did I miss, question-wise? How many questions into this are we?
Just 2.
Didn't do too bad. Okay, sorry, everybody. So size. Well, it all depends on how you look for these things. So each kind of imaging modality has its sort of limited ability to pick up tumors. I always make a very big point that these are biochemical diagnoses to a large extent with functional small tumors. And even if you cannot find them, that does not preclude an operation. And I think that's probably the most important point. You can look as hard as you can, and you can find nothing. But if I get patients who have a gastronoma syndrome, and we have proven that they've got the gastronoma biochemically because the gastrin is elevated and the acid is high. So they're making acid and they've got a high gastrin. I know there's a gastronoma there. There's a few differential tumors conditions you've got to exclude. But even if I cannot find it, I'm sending that patient for surgery because I know that we're going to find it 95% of the time. Same thing will happen in patients who have insulinomas, for example. Very, very small tumors, you may not find them. But that having been said, to get to the specific question at hand, how big do they have to be found? It depends on where it is, and it depends on what modality you're using. So the pancreas, for example, has nice distinction between the tumor and the pancreatic body. If you look at it with endoscopic ultrasound and you put the machine right up against the wall of the stomach and you shine it through the wall into the pancreatic body, you can get lesions as small as 3, 4, 5 millimeters. Tiny little things that you can find on endoscopic ultrasound. The octria scanning or gallium, which is better than octria scan, or MRIs and CTs, those are all very different. Each type of modality and each location varies. The functional imaging, octria scan, gallium scan, PET, for example, those are dependent to a large extent on receptor density, how many receptors there are for the substrate to bind to, as opposed to the actual size of the tumor, although they are correlated to some extent. But on endoscopic visibility, our new high-definition endoscopes are unbelievable. When we got the new endoscopes, we started taking out all sorts of little things that we saw in the wall of the stomach and the wall of the colon, and oh my God, they were normal because we didn't know what we were looking at. The high definition was so good. It was like going from analog TV to high-density TV. And so very, 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 very small lesions you can see down to millimeter size. Again, dependent on the background and dependent on receptors.
Dr. Ainati, question for you. How can a physician tell if a tumor is primary or not? With a subsequent question, are appendiceal carcinoids generally primary?
So how can you tell if a tumor is primary or not? Well, if you're dealing with a tumor of a primary organ, whether it be esophagus, stomach, duodenum, pancreas, anywhere in the GI tract, those are usually the primaries. When you have tumor that's, say, in the mesentery of which is the blood supply and where the lymph nodes are of the intestinal tract, those are usually spread from somewhere else, usually some part of the GI tract. So oftentimes you may find the metastatic deposit first, which happened last week, and we then look at the distribution of intestine of where that, say, lymph node would be in the mesentery, and then oftentimes we'll be able to find the primary. When it comes to the liver and it comes to neuroendocrine, certainly by far most of those tumors are going to be metastatic lesions. However, rarely you'll come across somebody who has a primary neuroendocrine tumor involving the liver itself. Sometimes, we'll do a very extensive search looking for the primaries, and we're not able to find them, and they might pop up a couple of years later where we can clinically image them. When it comes to the appendix, I would certainly consider, for the most part, that an appendiceal tumor is going to be a primary tumor. It's unlikely to have an appendiceal metastasis.
Let me just add, I agree entirely. I don't think I've ever seen a metastasis of the appendix, but two things I'd make about that point. This is a point that Dick Warner keeps on making, and clinical experience really counts. There are these CUPs or CUPs, carcinoma unknown primary, carcinoid of unknown primary. Patients will present with metastatic disease in the liver, no known primary. Occasionally, if you go back, that person had an appendicectomy 5, 10, 15, 20 years ago. So that's something to just always think about. And the other point I'd make about primaries is you can get multiple primaries. So you might have what looks like a primary, but you might have more than one primary. And we are now finding with small bowel carcinoids that there's an association, a familial association, the chromosome abnormality on chromosome 18, where people can get multiple small little primary tumors in the small bowel. And so, you might take out 3 and there's 3 left behind. NCAN syndrome, which I mentioned also, remember, often has different primaries. They might have a Zollinger-Ellison bunch, like you saw on the one slide I showed, but they might also have a gastric type 2. They might have a PPoma in the pancreas. They might have an insulinoma in the pancreas. They might have a pituitary primary. They might have a thymic primary. So you get multiple primaries, and they're not all metastases. On the other hand, we do see people who get metastases in places where primaries occur. And it's not that uncommon, for example, to have a person who had a small bowel tumor many years ago that is metastatic in multiple places, and something will pop up in the pancreas, but it's a metastatic pancreas. So you can go both ways.
If I may follow up on Dr. Metz's comment, Dr. Howe, our endocrine surgeon, 2 weeks ago had a midgut or small bowel and found 75 multicentric carcinoids. And that brings the point that when the surgeon goes in, they start very high up, like at the beginning of the jejunum, and come down and feel for the beads. Yeah, we had one 3 months ago of 125 multicentric carcinoids. And our series is about 46% of the midguts are multicentric, as Dr. Metz suggests. And that really behooves the surgeon and who you get to do that kind of careful palpation at the time of surgery. Because many times some are left.
Okay, thank you. I have a couple of questions I'm going to lump together for Dr. Thomas. We're going to hear from Dr. Thomas this afternoon, but I think this is going to be right up your alley without trying to give away your thunder ahead of time. First question. Some patients get Sandostatin 20, Sandostatin LAR 20, some 30, some 60. Some get shots every 28 days, some more often. Is more better? Or should we get only enough to control symptoms?
I think that's a great question. A lot of times we're, just by the way, I'm G. Thomas at the University of Florida Medical Oncology. A lot of times I'm looking at the patient, I want to know the site of the disease, the grade, the functionality, stage, all that information sort of applies to how I think about a patient. If they have no symptoms whatsoever related to the disease, you know you have great data for somatostatin analog at a dose of 30 milligrams every 4 weeks. And now the new drug with lenalidomide at 120 milligrams every 4 weeks. So for that type of patient where you're trying to control the disease, it makes sense to go at 30 or 120 of octreotide and lenalidomide respectively. Any dose higher than that, I don't think we have a lot of data for that. I don't think there's a lot of expert and maybe anecdotal opinion out there to say that higher doses might be better, but there's no hard evidence to say that octreotide 60 is any better than 30 at this point in time. Now, if we're talking about not disease control, we're talking about symptom control. So if they're, say, you're very syndromic, you have diarrhea, flushing episodes, and 30 is no longer cutting it. You now need to take the shot every so often, every 8 hours, 100, 200. I have a lady who's taking 600 micrograms every 8 hours. I've heard of folks doing a pump to try to control the symptoms. Again, what you're trying to do is trying to get on top of your symptoms because it's not about the disease, it's about your quality of life. And if we can try to control the symptoms with higher doses of somatostatin analog, then that's not unreasonable to do that.
I want to mention maybe telotrestat.
Oh, yeah.
Just a point and follow-up to Dr. Thomas. When we had only the sub-Q for 10 years, from 1989 to 1999, a phenomenon started to be observed. And when you think about the target tissue that the hormone works on, they have receptor subtype 2 as well, but they don't have as many as the tumor has. So if you can control the symptoms, you are giving more than enough to control the tumor, because it takes more to control the symptoms because it's antagonizing at the target tissue. So the point is, more is better sometimes, and when it is, you can adjust your long-acting or your depot.
Just another follow-up, as we've mentioned, telotrestat, which I'll talk about in my talk. It's a relatively new drug that helps inhibit the conversion of tryptophan into serotonin. Serotonin sort of drives the diarrhea and flushing. There's a new drug that's currently in clinical study that can actually inhibit that conversion of tryptophan into serotonin, and I'll mention that in my talk.
So let me just emphasize the point that Tom made. More may be better when you're controlling symptoms. Okay, and if you're using it to control symptoms, the secondary beneficial effect is to control tumor growth, which is not necessarily dose dependent when you get above 30. Follow-up question to that for Dr. Thomas: can Sandostatin LAR 30 be administered for many, many years without any other medical consequences? Okay, which is a terrific question.
Yeah, I definitely have folks who are on years with therapy. I'm sure probably decades on therapy. Some of the long-term effects that I see from octreotide therapy in the long term, and one well-known one is a pancreatic insufficiency, where this drug can suppress your pancreas from making enzymes that help break down the food. Your pancreas is constantly making enzymes to break down the carbs, the proteins, the fats, and so if you're taking octreotide regularly for a very long time, it can suppress that exocrine function of the pancreas, and that could lead to a different kind of diarrhea, this fatty, oily type of diarrhea. I'm sure the GI folks kind of see that a little more often. Maybe it's the type where it maybe smell a little longer in the bathroom, more so than what you have with your normal bowel movements, perhaps. That would be the long-term effect that I've
Right,
seen.
and the take-home point on that is if you're on Sandostatin and your diarrhea comes back, it's not necessarily the diarrhea of your carcinoid syndrome coming back. It doesn't mean the drug isn't working. You have to go through the quality of the diarrhea and the symptoms, etc., and you may just simply need some replacement pancreatic enzymes to control that. Other long-term side effects of Sandostatin can be thyroid insufficiency. I do test my patients for thyroid function every 3 months. Hyperglycemia actually can be hyper or hypoglycemia, but hyperglycemia is a little more common. And it can, if a patient is a pre-existing diabetic or pre-diabetic, it can exacerbate the disease. And of course, gallstones. And if you're lucky enough to have your gallbladder taken out at the time of surgery, then that of course lessens eliminates gallstones, but you can still get sludge, and that can be
just in follow-up, absolutely. In terms of the thyroid, it's a known mechanism that not only is growth hormone suppressed with somatostatin, but the TSH, which drives the thyroid function, is also naturally inhibited. And one of the things you have to be careful of when you order thyroid tests, you order the TSH and the free T4, but you need to look at the free T3, because almost always that's the one that's inhibited, and that's the one that is associated with biologic function. The other thing regarding the enzyme replacement is point on, because I think we've seen over time of 10 years that that's one sustained phenomenon where the meal-related enzymes are not released. And, there's the animal enzymes. Many of you are taking pancreolipase, and David could speak to this. But there's a vegetable enzyme that's kosher. It's called Digest Gold. You can get on the website. And we're using the pineapple papaya chewables, 4 to 5 before each meal. They're palatable. You can buy a bucket of them from Walmart or GNC stores and take them with you when you're eating kind of high-fat component meals. But they work very, very well. People sometimes prefer it over the animal enzymes like Creon or Viocase or Zenpep.
One other point that's really difficult to separate out is diarrhea, as you've heard, is not always carcinoid syndrome. And in fact, people who have other causes for neuroendocrines or non-functional neuroendocrines who are on octreotide have reason to get diarrhea from a variety of causes. So there are things that I mentioned that you need to think about. Number one, the easiest thing is antibiotics. So octreotide retards motility in the bowel. So it really gives you what's called an ileus, paralysis of the bowel. People get non-specific just discomfort. And you don't want to stop this drug because it really helps. But if you have dysmotility or poor motility in the bowel, the bacteria that live in our bowel multiply. And so you can get bacterial overgrowth, which is a common cause of diarrhea. In fact, we've developed a lot of studies now. People are very interested in what's called the microbiome, the bacteria that live in our bowel. There are 10 times more bacteria living in your bowel than you have cells in your body. Isn't that amazing? It blows my mind. So there's zillions and millions of bacteria that we're all living with. And if we change the motility in our bowel, those bacteria enjoy it. And every time you feed them, They get up and they run around and you get diarrhea and you get cramping in the abdominal canal. So the first thing to think of is bacterial overgrowth, which you can test for or just treat because it's easy. You get a non-absorbable antibiotic, see what it does. The next one is the people that have the small bowel and right hemicolectomy surgery who don't have normal circulation of bile acids. And so those bile acids, which would normally get absorbed in the small bowel and circulated again, end up getting delivered to the colon. And the colon doesn't like bile acids, and you get a bile salt diarrhea. So you can block that with a medicine called cholestyramine, which is normally made to release to low cholesterol. But cholestyramine is great for binding up bile. Important, if you're on cholestyramine, don't take it with any other medicines because it's going to prevent the absorption of that medicine. And don't take it with your food because you're not taking it for cholesterol binding. You're taking it to bind up the bile. You take it between meals. And that's easy, another way to deal with diarrhea. Then if those don't work, I always go to pancreatic enzymes, as we've just discussed, because pancreatic insufficiency is common, either because it's been operated on and or because you're on octreotide, which dries up all secretions. And those are three very common causes for diarrhea in patients with neuroendocrine tumors that have got nothing at all to do with the carcinoid syndrome, with a vipoma syndrome, or any other cause of the diarrhea.
Okay, so neuroendocrine specialists, we're all obsessed with diarrhea, obviously.
Just one point, and David alluded to it this morning, but it's hard to have a syndrome, as Dr. Metz showed today, without a high circulating level of a peptide or a hormone that's associated with that. For instance, gastrin, high gastrin, and high acid with ulcer disease, too much insulin with profound hypoglycemia. The same obtains with the mid-gut ileal tumors. And these are, in the hormone we've been talking about and has been sort of in the closet for many years is serotonin. And if I have patients that come in and their serotonins are less than 200 or even 250, it's very unlikely that they're going to have a serotonin-induced type of diarrhea. And therefore, the other causes and the other suggestions that Dr. Metz has made is very keen. But you have to have a high level to have a syndrome. And serotonin in the last 8 years, since the paper in 1984, all the big labs can do serotonin very well. And they can keep it and measure it. And there's at least 4 labs in the country that measure it very reproducibly. And for midguts, that's absolutely a marker that tells many stories, especially as you go forward with your treatment.
Okay, we're going to use that as a segue onto the next.
I just got a
Sure.
diarrhea comment in because I'm the GI surgeon here, and of course we're all obsessed with diarrhea and stool. One, in terms of this, if there is pancreatic insufficiency, there are some things like papaya that have natural enzymes. But if you truly have pancreatic insufficiency, you really need pancreatic enzymes, and they are a porcine product. So you mentioned it being a kosher issue, and generally, if you talk to your rabbi, and it's a medicine for a medical reason, that's all off the table. So generally that hasn't been much of an issue from that point of view. If you have ever had any antibiotics for whatever reason, that can change your bacterial flora. And so again, me working in a hospital filled with CRE and MRSA, I eat yogurt every single day. So yogurt, active culture yogurt is good, but there's also probiotics. But remember, there's 2 types of probiotics. There's bacteria and there's yeast probiotics as well. So the yeast one, so that one oftentimes gets overlooked. So something like Florastor, if you're having an overgrowth problem, is a good idea. When it comes to the bile acids, absolutely. Even if you have a cholecystectomy, you can have an osmotic diarrhea from fast transition of bile acids to your colon, which your colon doesn't like. And so generally we'll start off with something like Pepto-Bismol, something easy like that. And if that coats, it'll work. But then if that fails, then we'll generally go to Questran, which is a gram 4 times a day. But if you really need to know, there are things that we can measure. We can measure the amount of fat. We can measure the amount of enzymes in your stool to actually tell you if you're malabsorbing or not. But if this is a diarrhea, and then by the way, think about stevia too, right? We're all on this low carb thing, right? We do Splendor stevia. Stevia definitely gives you osmotic diarrhea. So if you're having 5 stevia per coffee 10 times a day, you might get a little diarrhea. So, but if you are outside the normal range of long-acting octreotide, lanreotide, generally what drives symptoms, or oftentimes what drives symptoms of diarrhea, is liver disease. And so is there an opportunity for liver-directed therapy to try to debulk that disease to help with those symptoms? So that's the question that needs to be asked. Thanks.
Okay. So that basically answers our next question, which is, does the fact that you have multiple diarrhea, quote unquote, accidents mean the tumors are proliferating or growing? And the answer is clearly no, not necessarily. Question for Tom, our historian. Okay. Many organizations are now using the term NET instead of carcinoid. My understanding is that carcinoids were a type of NET. Are the two terms interchangeable now? So maybe a little clarification on the nomenclature.
So in 1907, Obendorfer described, as David pointed up, the carcinoid is the German word for carcinoma-like syndrome, because the cells looked normal, but they were migrating, and so he coined the term carcinoid, which for 100 years carcinoid included all of what we now know as neuroendocrine tumors of the different systems. In the year 2000, I have a picture of Solchia. He convened the World Health Organization of pathologists in the year 2000, and they separated, they termed the cell that gives rise to the tumors neuroendocrine cell because of their common property, and then they broke down where the neuroendocrine tumors can arise. Carcinoid is now one of the neuroendocrine tumors in the neuroendocrine tumor system. Carcinoid of the lung and carcinoid of the midgut are the two valid carcinoids. There's a very small percent of true carcinoids in the liver. In the pancreas primarily. But carcinoid tumors are defined by the cell type, which is the neuroendocrine cell, or used to be called the aphid cell. But it makes the amine serotonin, and it's the serotonin content of the carcinoid tumor that gives it. It's really, if you were to call these tumors anything, you'd call them a serotoninoma, but you don't. Carcinoid is the term reserved for the gut, midgut, and the lung, mostly. And then they are under the broad title of neuroendocrine tumors.
Okay, great. Two questions for our gastroenterologist and our surgeon. Approximately how long can a tumor be growing before it causes symptoms? And the second question, which is a very good question, is the PET scan the best diagnostic test to determine if a tumor is coming back?
I'll start. So how long has the tumor been there before it causes symptoms? Well, that's a very difficult one. So if you take autopsy specimens, so these are people who died from unrelated events, 1 in 100 people have a neuroendocrine tumor in the pancreas at autopsy. So there are many people out there who have neuroendocrine tumors that can be there for eons and not do anything at all. And that's a centimeter in size is what was found on that particular autopsy series that I'm thinking of. On the other hand, I did show you a gastronoma that was 2 or 3 millimeters and was causing profound symptoms in the patient. So size doesn't give you an idea of, number one, how long it's been there, and number two, whether it's causing any syndrome. As Tom mentioned, which is something I would support very, very importantly, be very wary of somebody calling a tumor a somethingoma based on the pathology and the biopsy and the path staining. So you can take a Zollinger-Ellison syndrome gastronoma tumor and you can stain it for somatostatin and it'll stain positive, or for VIP and it'll stain positive. Doesn't mean you've got the Vipoma syndrome. So what the hormone stains for is not the syndrome. In order to get the syndrome, you have to have the blood level of the product that causes the syndrome. And so this whole carcinoma debate is really, it's a accident of history. that we talk about carcinoids being mid-gut carcinoids. It's just that the term is absolutely stuck. But carcinoid really just means like a carcinoma. But if you're a pathologist and you look at a neuroendocrine tumor under the microscope and you just see tumor, sometimes you can't tell the difference between a carcinoid of the small bowel, a carcinoid in the pituitary gland, or a carcinoid in the thyroid necessarily, because they look the same. And they may stain for all sorts of different things. So size doesn't make that distinction, and duration of disease is very, very, very variable. When it comes back, biochemical testing is the way to do it. So my approach is if I can show that somebody has had a small tumor resected, and whatever tumor marker I'm using to monitor them is repeatedly negative, and there's no evidence of disease on imaging, I don't do imaging. It's the biochemistry that's going to tell me this tumor is coming back. And if suddenly the biochemical marker goes up, then I'll look for imaging. So imaging might be very helpful, but you can scan people to death. You know, you've got to be careful about just testing and testing and testing and testing. There's the radiation risks, number one. And number two, there's the anxiety of getting this test done all the time when you know this is a very slow-growing tumor that's not necessarily going to change. So I use biochemistry. If I have no evidence of disease, I use biochemistry to determine my next scan.
Perfect. I totally concur.
Absolutely, and my patients in the room know that I'll do the blood tests and on a regular interval for my patients, but I'll be very reluctant to send them for scans unless something pops up that prompts me to do that. Okay.
Yeah, no, I would agree completely. You know, you're asking how long will it be before a tumor develops symptoms? Well, it depends on the biology of the disease. It depends on the biology of the tumor. Is it a secretory tumor or not? And again, we can have 10, 15 centimeter tumors in the tail of your pancreas and you not know it's there, and it's been there for a long time. And as you mentioned, you can have a 2 millimeter insulinoma and bottoming out your blood glucoses pretty quickly. So again, it's not like pancreatic cancer where there's a fairly consistent biology of disease. These have such a wide variety of biologic activity and growth rates that it would be hard to answer that question.
Right, and
there
also
was another question about is PET scan the best scan?
Well, let me just, before we go on to that, when we talk about symptoms from this disease, there are really two distinct categories of symptoms. One's going to be the biochemical activity of the disease and what it produces, the peptide production, the hormone production, etc. And then there's going to be symptoms that could be produced by the bulk of the disease. And that's going to be very different. So when you talk about, and that's a matter of sheer size, and that could be what we used to term, cancer pain, the bulk of the disease, the pressure, etc. So two different categories of symptoms.
Right. There's other symptoms as well. There's complications of the disease, such as bowel obstructions, which we see regularly. And then when you have a lot of mesenteric disease, mesenteric ischemia, where the blood supply is getting cut off to the intestines. So that's, again, another range of symptoms there.
Okay, so PET scan. Run-of-the-mill FDG glucose PET scan, in my opinion, really doesn't have a place in neuroendocrine tumors. You guys feel any different?
Okay, look, if I could just, there's a caveat. It's developing, and I totally agree. When FDG was first described in 15 patients with neuroendocrine tumors, it came away saying it was of no value, and that really, I think, hurt the field of FDG PET because it looks at the speed, if you will, or the metabolism of the tumor, whereas the gallium DOTA-TOC, the gallium PET scans that you're hearing about, looks at the functional aspect, the receptor itself on the tumors. But data is now developing, and there's 3 French articles on the PET where they give a value. It's called the max SUV, and they are saying now that a max SUV in a neuroendocrine tumor of 4.5 or greater, and it's an absolute number because it's quantitative. PET scans quantitate either the receptor or the speed of the tumor, that those might be better served with a more aggressive approach of therapy, like chemotherapy.
Well, is that dependent on the Ki-67?
It does and it doesn't. There's 2 things. There's the Ki-67 of greater than 20, which puts it into a grade 3 category.
In which case a PET scan might be more helpful.
Would be helpful, and also 48% of a high grade 3 up to 50% will express the receptors. And when you have the receptors, you also have the ability to use octreotide with the Hal says maybe a more aggressive approach to chemotherapy. So you don't want to throw the baby out now with the bathwater, because and now a lot of centers are doing both an FDG PET with the higher grades with the gallium-68, and that gives you wonderful information. The only other comment it would be regarding the time before they become manifest. Arthur Vinnick has shown, or always used a table which talks about 7 to 8 years on average. But remember what David said this morning, 80% of the neuroendocrine tumors have that very special receptor. And when you have the receptor, that means that your own body is protecting the growth of it with somatostatin. So I tell my people the good news is your tumor has been slowed because your body has slowed it down with the hormone somatostatin, and that's why it's grown just slowly. The bad news is that hormone has kept the tumor from growing and hasn't been clinically manifest. So I mean, your own body it's directly related to what your own hormone can do to keep the thing from proliferating. And then when they start getting bigger and bigger, then they become manifest.
Okay, just want to keep moving because we have a limited amount of time. One quick question that I think has already been answered, but I'll do it again. Are somatostatins used with peanuts? The answer is yes. And can somatostatins be used concurrently with Sutent? And the answer is yes. Okay. Let's go on to Tom. I want you to do this quickly because we do have one more category to go, but this is right up your alley, okay?
My own.
I'm going to rephrase this. Can CEA be used as a surrogate marker for patients where all other markers are negative? And the corollary to that is, when do we get concerned about markers? Just at the high end of normal range, 10% over normal range, or double, etc.? What is your threshold?
So I want David to weigh in on this. The CEA is that would obviously apply mostly to the intestinal, I would think, the intestinal neuroendocrine tumors. I can't speak to pancreatic, and David could speak to that. It's hard to explain. The radioimmunoassays have upper limits of normal, but those upper limits of normal really represent 2 standard deviations above the mean. That's how all commercial assays are reported. But given that, there's a third deviation wherein beyond it, slightly above it is normal. So it's a very difficult question. With pancreastatin, it should at least double. With serotonin, the marker is absolute. 200 nanograms is what we all have the high limit on. So anything above 200 nanograms usually means there's an abnormal amount circulating. And with insulin, it doesn't matter the level. If you have an inappropriate release of insulin and low blood sugar, that's inappropriate. So insulin can be just a little bit up, but if it's up at the wrong time and you have low blood sugar, it's abnormal. And that's the way you kind of have to look at the assays. Anything above their 2 standard deviations means something. But in the case of CGA, there's multiple things that can affect chromogranin A. CEA, David, can you speak to that? I don't measure it.
Absolutely.
Too many Davids. David A, David B.
We're all beloved here. So the CEA. So generally, for a well-differentiated neuroendocrine tumor, they generally are not going to secrete CEA. However, the more or the less differentiated a tumor becomes, or if you have a carcinoma with neuroendocrine features, they can secrete CEA. Typically, as we all know, the typical tumor marker for a neuroendocrine tumor is a chromogranin A. Other tumor markers that we use in GI and abdominal diseases, CEA, again, is a general tumor marker for any adenocarcinoma or carcinoma. CA19-9 would be specific for pancreatic. CA125 would be for, say, ovarian. Alpha-fetoprotein would be for hepatocellular carcinoma. And what I tell people is that I wouldn't be so hung up on the absolute number. Sure, there are absolutes. And I wouldn't get so much hung up on normal ranges, because those ranges are there for a population of people. And so I think when you're talking about individualized care, that number is relevant to that individual. So for instance, if you're following someone with colon cancer, and you have a CEA level of 0.5, you do colon resection, liver resection, whatever, CEA is 0.5, follow 0.5, 0.5, then it goes 1. Now the upper limit to normal is 5. So you go 0.5, 0.5, 1, 1, 1.5, 2, 3, 4. You're still normal, but for that individual, that's a change in their CEA level, which could be a sign that there may be recurrent disease. So I would think of the same thing in terms of CA19-9. That's the number that bounces around a lot. CEA for sure, that's a fairly consistent number. It's generally low, and again, hard to elevate in neuroendocrine. And I would also view the same way as chromogranin A, is looking at the differences in the number for that individual over time.
Okay, I'm going to have to move on. I just want to say that I agree wholeheartedly. I look at, for me personally, I like to look at trends, and trends are very important, especially in a disease that is basically relatively slow growing. So I want to be sure of what the number is, and I want to see trends. As far as the CEA is concerned, I don't know why this particular patient's doctor did a CEA, if they were looking for something else. CEA is not an approved screening test, so you're not going to do it to look for a colon cancer. So I don't really know why it would even be done in this case. It's not a test that I generally do for neuroendocrine tumors.
Just to comment on trends, I think it's so important. So if you're getting labs done outside at your own area, keep it with the same lab and look at the trends. It doesn't because many times people get a value like chromogranin A from one lab, and it's totally different from another lab, and it causes a lot of concern when it really shouldn't, because each lab has their own normal range. But looking at the same lab and the trends is very, very important. It gives you a lot of information.
Okay, last question. I strongly agree that surviving a neuroendocrine tumor takes an interdisciplinary approach. Why then can it be so challenging and awkward to get different doctors to interact, communicate, and confer together on a patient's case? Well, I kind of disagree with that. But
Oh, I don't. I think that's a very big problem. It's American medicine at its best. We ask what we get for, and this is an issue. Our whole healthcare system is very difficult to navigate. I mean, one of the major people on my multidisciplinary care is a patient navigator. It's an important role. You need a nurse navigator. You need somebody to deal with all these insurance companies. I was just talking, which is why I was late here. What often we have is you can get your CAT scan done at one hospital, but your labs are getting done at another hospital, and the doctor you want to see is at a third hospital, and their medical records don't talk to one another. This is unfortunately what we have in the United States, and we are all to blame. We, meaning the patients, the public, as well as the doctors. We created this whole system, and we have to live with it.
I think if you have a captain of the ship who's willing to take that extra step and do that for you, it can be done. Further, the follow-up question and the final question is, personalized care has been emphasized. How do we change the medical landscape given the constraints of insurance companies? And the answer is sitting right in this room. You talk to Marianne, and you talk to her husband, and you get involved with NCAN, and that's how it's going to change. It's only going to change from patients acting on their own behalf and getting the system to change, I think. For us doctors on here, we've all been frustrated with dealing with insurance companies and with the government and getting things done because they tend to exclude us from decision making more than they include us. And that's been a problem, and I hope that'll change, but I don't know.
Patient advocacy, I think, is really important, and I would say organizations such as this really are essential. We set up our interdisciplinary groups. We really need support to actually make these sort of things work. So that's why this is such an important conference for me.
If I didn't get to any of your questions, I'm sorry, but there will be another question and answer period at the end of the afternoon session, which will address some of the questions I didn't get to. Thanks very much.
Thank you to our panel.